My topic is the classification and the treatment strategy of Atlanto-axial dislocation. I'm Dr. Chen from Junction Hospital. From etiology, we can find that there's many regions for the Atlanto-axial dislocation, and some trauma can lead to Atlanto-axial dislocation, C1-C2 dislocation. And also there's a lot of congenital regions such as Down syndrome, and also in clinic, most frequently we can see that if there is occipitalization of atlas, this kind of patient very often suffer the basal invagination and also Atlanto-axial dislocation. So in clinical work, we always meet two kinds of C1-C2 dislocation. Type 1 is C1-C2 dislocation without basal invagination, and type B is C1-C2 dislocation, but accompanied with basal invagination. Both of these kind of C1-C2 dislocation, we will release the facet joint, and we found that if the facet joint are totally released, we can first with the distraction between the facet joint, we can release the anterior tendon band, and that means that's a lot of tendon anterior between C1 and C2, and release this anterior tendon band, we can get the reduction more satisfactory, and also we can unlock the facet joint when we distract between the facet joints. When we distract between the facet joint, we can release the locked facet joint and also release the anterior tendon band, and then we put a cage in the facet joint to keep the reduction stable. To release the facet joint, we have designed several equipment to help us to release the facet joint. This is how we use this kind of instruments in the operation. This is a CT scan in the operation. We can see the instruments, the tools in the facet joint. For type 1 C1-C2 dislocation, without this kind of dislocation without basal invagination, so usually this kind of C1-C2 dislocation are always reducible. We just there's only transverse dislocation between C1 and C2, so we just push the C2 anteriorly, and we can get a total reduction between C1 and C2. But there did some cases with a severe blockage between the facet joint. For example, in the this is a reducible cases, and it is a surgery. Yesterday I do for left surgery, and you can see if we put a very small cage in the facet joint, we can get a more stable reduction after operation, and in the future we can get a very tight bone fusion between the facet joint. And there did some severe case in this kind of patient. For example, this case is also odontoid, but it is irreducible. We can see that there's a lot of bone fusion on the facet joint, on the bilateral facet joint. In this kind of case, we should do a very complete release in the bilateral facet joint. and put a cage in the first joint as a pivot. With that cage, we can perform posterior compression between the screws on C1 and C2. Then we can get a satisfied reduction of this kind of dislocation. For the type B C1-C2 dislocation, that means this kind of C1-C2 dislocation is accompanied with basal invagination. It's most common kind of patient we meet in China. This kind of patient also always suffered occipitalization of C1, and because the disappear of C1, the C2 move upward, and basal invagination happened. And for this kind of C1-C2 dislocation, first we should push C2 downward to reduce basal invagination, and then push the C2 anteriorly and reduct C1-C2 transverse dislocation, and we can get the final result. So with this kind of patient, we should put a much larger cage in the first joint with the height of the cage can compensate the disappearance of C1 lateral mass, and with the cage we can reduce basal invagination, and then with the cantilever technique we reduce the C1-C2 transverse dislocation. It's a typical type B C1-C2 dislocation. The patient suffered occipitalization of C1 and basal invagination, and also C1-C2 transverse dislocation. And we put a cage in the first joint bilaterally, and then with the cantilever technique we can get a satisfied reduction between C1 and C2. And this kind of technique can be used to revise surgeries. This patient have been performed surgery formally, but the first surgery does not get satisfied reduction, and only get fusion from C0 to C2. And with revision surgery, we release the first joint and put a cage, implant a cage in the first joint. And with this kind of technique, we can get a total reduction. And also, we meet a lot of this kind of patient have performed posterior fossa decompression, and but the surgery will not solve the problem of the patient, and we have to perform revision surgery. We decided the first joint bilaterally and implant cage, and with internal fixation system, we can get a complete reduction between C1 and C2. Also, we can use this kind of technique to reduce the rotational C1-C2 dislocation. This patient was suffered ankylosing spondylitis, and he has a very rigid rotation C1-C2 dislocation. In the operation, we release the first joint bilaterally and plant a cage in the first joint, and with C1-C2 internal fixation, we get complete reduction of this rotation dislocation between C1 and C2. There did some cases. I do not have. I'm not sure I can treat that kind of patient with a posterior approach. So I think anterior approach is still necessary. It's a very useful compensate for some kind of patient. In this patient, it's a C1-C2 dislocation. But to study the CT scan, I found that his C1 lateral mass has been slide to the anterior. Sorry about the website. And for this kind of case, if I'm not sure with a posterior procedure, and I will from 3D CT scan, we can see that if from posterior approach, I can hardly get into the facet joint. So with this kind of case, I use anterior approach. I remove the odontoid and perform partial C2 resection, and with the posterior approach, I perform internal fixation and fusion. Yeah. So to summarize, releasing and distraction between the facet joint is a key step for posterior reduction for any kind of Atlanto-axial dislocation. And cage implantation is very important to restore C1-C2 dislocation and keep the reduction stable. Pre-operation study of the radiological images is important to avoid complications for this kind of surgeries. Thank you.